Professor Mutwalli. All right. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you, Professor Mutwalli. Good evening, everyone. I would like to welcome everybody. I'm Dr. Samuel Obeidi. I'm an assistant professor and chairman of medicine department at University of Jeddah. It gives me a great pleasure today to introduce Dr. Gabriel Contreras, who is a professor in the division of nephrology and hypertension at the University of Miami. Professor Contreras earned his medical degree in 1984 from the University of Guadalajara. He's since trained in internal medicine, nephrology, hypertension, and critical care. And also he earned a master in public health between 1989 and 2003. He joined the School of Medicine at University of Miami in 1996. During his time as faculty and the Department of Medicine, he has been involved in development and establishment of successful clinical research program in the Division of Nephrology with 24 research grants, more than 100 publications in peer review journals and textbook. Professor Contreras is a well-known figure in the field of nephrology and research. Before we go to Professor Contreras, I would like to remind everyone, please, if you have any question, just place them into the Q&A section. Without further ado, I welcome Professor Contreras. Professor, the mic is yours.
Well, I'd like to first thank the Society of Nephrology of Saudi Arabia for inviting me to discuss the management of lupus nephritis. Where do we stand? Here are my disclosures. During the presentation, I divided the presentation in 4 different areas. We will first review the risk of chronic kidney disease and mortality associated to lupus nephritis classification. Now, this slide illustrates the classification of lupus nephritis with the last revision in 2018. The classes are categorized from 1 to 6. I gotta say that it's not a continuous of the same disease, but some of those classes are very similar, like class 1 called minimal mesangial, where the light microscopy is normal, but you see deposit by immunofluorescent or electron microscopy. And class 2, which is mesangial hypercellularity, where you see the mesangial changes in the light microscopy. Now, class 3 and class 4 are the most severe form of lupus nephritis. The two are distinctive by the degree of endocapillary hypercellularity. In class 3, less than 50% of glomeruli have those histologic changes. In class 4, 50% or more of the glomeruli have endocapillary hypercellularity. Now, the new revision removed the subdivision of class 3 and class 4 of segmental and global. That's no longer needed. Now, class 5 is the membranous glomerulonephritis, which can be found in combination with class 3 or class 4. And class 6 is chronic glomerulonephritis, where more than 90% of glomeruli are globally sclerotic. The new revised classification remove the nomenclature of active with chronic or chronic changes and replace that with the activity index and chronicity index scores. Now, this slide comes from our group that illustrate the probability of remaining free of doubling creatinine and stage renal disease of dying. And as you can see, the patients with class 3, class 4, and 5, they have the worst outcomes over time. Now, I'm going to move now to the second section of the talk, the abnormal processing of nucleosome in lupus and the value of remission and relapse during treatment. Now, this slide illustrates the pathogenesis of immunity, of autoimmunity, starting with an abnormal processing of apoptotic bodies by the patient's own cells and the lack of internalization of nucleosome of apoptotic bodies that are taken by the immune system by antigen-presenting cells, and they're presented to the T cells in the first signal, where you have the interaction of the major histocompatibility complex with the T cell receptor. Now, in the initial step of activation of T cells, you need also the second signal, which is the interaction of different proteins in the cell, in those cells that fully activate T cells. Activated T cells initiate subsequently the transcription of cytokines. One of the most important is interleukin-2, and that's what we call the signal 3. Now, when the T cells is activated, they undergo proliferation, and they activate also B cells. And B cells require this important protein, the B lymphocyte stimulator, to mature and differentiate the plasma cells, which are the cells that produce the antibodies. And so in this particularly scheme of the pathogenesis of autoimmunity, treatments target different paths in this process. Cyclophosphamide, azathioprine, mycophenolate, mofetil essentially block the proliferation of T cells and B cells. Medications such as abatacept and belatacept can block the second signal and render T cells inactive. Calcineurin inhibitors block the transcription of interleukin-2 and affect primarily the third signal 3. And then you have specific B cell therapies now available, anti-CD20 antibodies, and antibodies against the B lymphocyte stimulators. Now, these Kaplan-Meier plots illustrate the value of complete remission in patients treated primarily with cyclophosphamide. What you see here in the y-axis is the survival free of end-stage renal disease or increased serum creatinine to up to 6 milligrams per deciliter or higher. Now, patients with complete remission, they do fairly well over follow-up of more than 10 years. Complete remission in this study was defined as a serum creatinine no higher than 1.4 milligrams per deciliter and proteinuria no higher than 0.3 grams a day. Patients with partial remission did much better than the one that did not achieve remission, defined here partial remission as a serum creatinine within 25% of baseline, accompanied by a decrease in proteinuria of at least 50% to a level between 1.5 and 0.3 grams. Now, what you see here in this slide is the time to complete remission and to partial remission. First, complete remission is not a very common event with the standard of care. It happens in about 10 to 20% of the time. Now, and it takes much longer. Only about half of the patient achieve complete remission by a median time of about 10.5 months. Partial remission is a much early efficacy event that occurred with a median time of 5.8 months. Now, this is another study that illustrates the value of renal response or remission at 24 months. In this particular study, patients with severe lupus nephritis were assessed at 24 months, and they were categorizing patients with complete response, partial response, or no response, and then they were followed, and the probability of remaining free of end-stage renal disease or dying was assessed. The definition of this of complete remission in this study is a little different than the prior one and include a normal estimated creatinine clearance of more than 90 mL per minute, accompanied by a urine protein to creatinine ratio of less than 0.5 grams. Partial remission was defined here as an estimated creatinine clearance no worse than 10% of baseline or normal, and accompanied by a 50% decline in the urine protein creatinine ratio to less than 1 if the baseline was subnephrotic of less than 3 grams or less than 3 if the patient had nephrotic range proteinuria or UPCR more than 3. As you can see here, patients with complete remission and partial remission tend to do very well when they achieve response compared to a patient with no remission. What you see here on the right side of the slide is another Kaplan-Meier plot that illustrates the probability of achieving or achieving a chronic kidney disease, remaining free of chronic kidney disease, defined as an estimated creatinine clearance less than 60. Based on the value of urine proteinuria, patients that had urine proteinuria of less than 0.8 grams a day, they do much better than those that have proteinuria of 0.8 grams a day or more over time. Now, this Kaplan-Meier plot illustrates the value of nephritic relapse compared to proteinuric relapses or no relapses. What you see here in the y-axis is the probability of not doubling the serum creatinine. Patients with nephritic relapse, they tend to do worse over time. Most of the patients with nephritic relapse over time have a low probability of remaining free of chronic kidney disease compared to patients that never relapse or have only proteinuric relapse. The definition of nephritic relapse in this study was an increase from baseline in the serum creatinine of at least 30%, accompanied by active urine sediment and increased proteinuria. I'm going to move now to the third part of the talk. I'm going to review the standard care therapies that include the use of cyclophosphamide, mycophenolate mofetil, and azathioprine in sequential regimens that had an induction phase and a maintenance phase. I'm going to review only 2 studies for this part. I'm going to review the ASPREVA lupus management study and the maintain nephritis trial. What you see here in this slide is the study design of the ALM study. The ALM study was a sequential factorial design that had 2 phases. The first phase is the induction phase that lasts 6 months, where in an open label fashion, oral mycophenolic mofetil was compared to intravenous pulses of cyclophosphamide every month for 6 months. The patient that responded at 6 months, they went into the maintenance phase that lasted 3 years and received double-blind, double-dummy, either mycophenolic mofetil or azathioprine orally. In the ALM study, 370 patients were enrolled with a mean age of 30 years old. Most of the patients, 61%, had class 4 lupus nephritis, 10% class 3 lupus nephritis, 16% class 6, 6% had the combination of class 5 and 3, 16% of them had class 5, 7% has class 5 and class 4. Now, 70% of the patients enrolled were incident patients. What that means is that they have first onset of lupus or severe lupus nephritis, and 30% were patients with relapsing lupus nephritis. 40% of the patients enrolled were of Caucasian background, 33% were Asian, 12% of African ancestry, and 15% of others. 65% were non-Hispanic and 35% were Hispanic. 85% as suspected were females. The patient had a mean baseline proteinuria of 4.1 grams a day with a creatinine at baseline of 1.1 milligram per deciliter. In the induction phase, all the patients received corticosteroids for 6 months. 185 patients were randomized to mycophenolate mofetil target doses of 2,000 to 3,000 milligrams a day for 6 months. And another 185 patients were randomized to monthly pulses of intravenous cyclophosphamide, pulses doses between 0.5 to 1 gram per meter square body surface area. What you see here in this slide is the treatment compliance Both groups received the same tapering down regimen of corticosteroids. By 24 weeks of 6 months, the patient required to be on no more than 10 milligrams of prednisone a day. The mean dose of mycophenolic mofetil in split doses was 2,500 milligrams a day. The mean dose per pulse of cyclophosphamide every month was 0.78 grams per meter square body surface area. The primary endpoint in the study was overall response that include complete and partial remission. Response was defined as urine protein creatinine ratio less than 3 in patients with baseline nephrotic range proteinuria, or a 50% decline in the proteinuria in those that were subnephrotic, accompanied by stable serum creatinine of no higher than 25% of baseline. In this bar graph, the bar graph illustrates the primary outcome of the induction phase. MMF was not superior to intravenous cyclophosphamide. 56.2% of the patients in the MMF group achieved a primary response, compared to 53% of the patients in the intravenous cyclophosphamide group. This bar graph illustrates the response to induction of patients with lupus nephritis according to the race, while the response rate to mycophenolic mofetil was very similar, regardless of the ethnic or race group, in range from 53.2% to 60.4%. The response rate to induction with cyclophosphamide varies substantially. In the non-Caucasian, non-Asian subgroup, fewer patients responded to intravenous cyclophosphamide, 38.5%, compared to a significant higher response to mycophenolic mofetil of 60.4%. Now, this bar graph illustrates a secondary endpoint, complete remission, defined in the study as normal serum creatinine, urine proteinuria of no higher than 0.5 grams a day, with inactive urine sediment. The complete response rate was very low, but similar in both groups, 8.1% in the cyclophosphamide group compared to 8.6% in the mycophenolic mofetil group. What you see here is some other secondary efficacy outcome, non-renal outcomes, including anti-double-stranded DNA, complement C3 component levels, complement C4 component levels, and albumin. Both therapy had effective reduction in the anti-double-stranded DNA, and both therapy have also an effective increase in complement C3, C4, and albumin level. These bar graph illustrate the percent of patients with adverse event by treatment. Any adverse events, any infections, serious adverse events, upper respiratory infection, urinary tract infections, lower respiratory infections, zoster infection, and mortality were very similar between the two groups. The most common adverse events were infection that was seen in about 60% of the patients in both groups. In the second phase of the ARM study, mycophenolic mofetil was compared to azathioprine in a double-blind fashion. The target dose for mycophenolic mofetil was 1,000 to 2,000 milligrams a day. Azathioprine dose target was 1 to 2 milligrams per kilogram per day. What you see here in this Kaplan-Meier plot is the primary endpoint of the maintenance phase of the study. Treatment failure, defined as proteinuric or nephritic relapse, sustained doubling of creatinine, end-stage renal disease, dying, or needing a rescue therapy for lupus nephritis. The probability of remaining free of treatment failure was substantially better and significantly better with the use of mycophenolic mofetil. 83.6% of patients remain free of the treatment failure event compared to 67.6% of the patient allocated to the use of azathioprine maintenance, with an absolute difference of 16% and an estimated number needed to treat of 6.2 patients to reduce one primary event when treated with mycophenolic mofetil. What you see here in this Kaplan-Meier plot is the primary secondary outcome of the second phase of ALMS flare, either proteinuric or nephritic flares. The probability of remaining free of renal relapse or flare was significantly better with mycophenolic mofetil with 87.1% compared to 76.6% with the use of azathioprine maintenance, with an absolute difference between the two groups of 10.5% and the number needed to treat of 9.5 patients to reduce the risk of or the incidence of flare. Now, this bar graph illustrate the percentage of patients with adverse event by treatment group in the maintenance phase. Again, any adverse event leading to withdrawal, leukopenia, all serious adverse events, cancer, and mortality were very similar between the two groups, the group that received mycophenolic mofetil maintenance and the group that received azathioprine maintenance. I'm going to move now to the second study, the Maintain Nephritis trial. And this is primarily a European study. All patients in this study received from day 1 to week 12 glucocorticosteroids, starting with 3 pulses of intravenous methylprednisolone, 750 milligrams every day for 3 days, followed by oral prednisone, initiating at a dose of 0.5 milligram per kilo per day. All the patients received mini pulses of intravenous cyclophosphamide, pulses of 0.5 grams every 2 weeks for 6 pulses, with a total cumulative dose of cyclophosphamide of 3 grams. And from week 12, the patients were randomized in an open label to receive azathioprine maintenance, 52 patients, or mycophenolic mofetil maintenance, 53 patients. What you see here in this slide is the characteristics of the patient that entered the study. 105 patients entered this study with a mean age of 33 years old. The most common lupus nephritis class was, again, class 4, 58%, class 3, 31%, the combination of class 5 with class 3, 3%, the combination of class 5 and class 4, 8%. 79% of the patients in this study were of Caucasian ancestry, 12% of African ancestry, 9% of Asian ancestry. And as expected, again, 91% of the patients were females. The mean 24-hour proteinuria baseline ranged from 2.94 to 3.63 grams a day. The mean zero creatinine was 1.02 milligram per deciliter. The target dose in the azathioprine group was 2 milligrams per kilo per day. The target dose in the mycophenolic mofetil group was 2,000 milligrams a day. This bar graph illustrates a secondary outcome of the study. Renal response, defined as 50% reduction in the 24-hour urine proteinuria compared to baseline. More than 90% of the patients in both sequential therapy groups achieve this secondary outcome. 92.3% of the patients in the sequential group of cyclophosphamide followed by azathioprine achieve renal response. 94.3% of the patients in the sequential group of intravenous cyclophosphamide followed by mycophenolic mofetil achieve renal response. This Kaplan-Meier plot illustrates the primary outcome of the study. The probability of remaining free of relapse. Relapse included nephritic and proteinuric relapse, nephrotic syndrome, and nephritic relapse definition was an increase in the serum creatinine of at least 33%, accompanied by proteinuria and or a triple of the urine proteinuria compared to baseline, accompanied by microscopic hematuria and a decline in the C3 level of at least 33%. As you can see in the y-axis, the probability of remaining free of renal flare was very similar between the two groups. In the MMF group, 19% of the patient had renal flare or relapse. 25% of the patient in the azathioprine group had renal relapse. The difference was not significantly better. Most of the renal relapses that occur in both groups were proteinuric relapses. These bar graph illustrate the percentage of patients with adverse events. Mild infections, hematologic adverse events, primarily leukopenias, anemias, hepatic adverse events, severe infections, gastrointestinal infection, and zoster infection were in general very similar between the two groups, with slightly increased mild infections in the azathioprine group and also slightly increase in leukopenia in the azathioprine group compared to the MMF group. Now, in the last part of my talk, I'm going to review three recently published studies. I'm going to review first the Multitarget Therapy Lupus Nephritis trial, a Chinese study. I'm going to review also the AURORA trial that was published in May in Lancet. And I'm going to review also the BLISS-Lupus Nephritis trial that was published in the New England Journal of Medicine in 2020. The multi-target therapy for induction treatment of lupus nephritis was completed and published in 2015. In that study, all patients in both groups received initially intravenous pulses of methylprednisolone of pulses of 500 milligrams a day for 3 days, followed by oral prednisone doses of 0.6 milligram per kilo per day initially, and then in a taper fashion. 362 participants with biopsy proving active lupus nephritis and proteinuria of at least 1.5 grams a day and a serum creatinine no higher than 3 milligram per deciliter were randomized in 26 centers in China. 181 patients were randomized to the multi-target therapy group that received the combination of mycophenolic mofetil, target doses of 500 milligrams twice a day with tacrolimus, a target dose of 2 milligrams twice a day. Another 181 participants were randomized to the control group that received monthly pulses of intravenous cyclophosphamide, target doses of 0.75 grams per meter square for 6 months. 362 participants, all of Asian ancestry, were enrolled in the study with a mean age of 32 years old. As expected, 90% of the patients were females. The most common lupus nephritis class was class 4 in 41% of the participants. 19% of the participants had class 5. 5% of the participants has class 3 lupus nephritis. 7% had the combination of class 5 and 3, and another 7% of the patient had the combination of class 5 and class 4. The activity index at baseline was 7 point out of 24, 24 as the highest score of activity. Most of the patient had in the study moderate activity in the biopsy. The chronicity index score at baseline was 1 point out of 12, being 12 the highest chronicity index. Most of the patients have no chronic changes or very mild chronic changes in the biopsy. The mean urine proteinuria in 24 hours at baseline, the participants was 3.58 grams per day. The mean serum creatinine at baseline was 0.8 milligram per deciliter. These slides illustrate the primary outcome. Complete remission, defined as urine proteinuria declined to no higher than to 0.4 grams or less in a 24 hours, with accompanied with absence of active urine sediment, normal serum creatinine, and a serum albumin no lower than 3.5 grams per deciliter. 45.9% of the patients allocated to the multi-target therapy group, the combination of mycophenolic mofetil with tacrolimus, achieved complete remission compared to 25.6% of the patient in the control group that received induction therapy with monthly pulses of intravenous cyclophosphamide. An absolute difference and significant difference of 20.3% that calculate or estimate a number needed to treat the 4.9 patients. What you see here in this part of the slide is the primary outcome, stratifying according to the class of lupus nephritis. Overall, the result was homogeneous, regardless of the class. The better response was seen in the multi-target therapy group compared to the intravenous cyclophosphamide group. This figure or graph illustrate the cumulative probability of overall response that include complete response and partial
Professor,
response.
I'm sorry for interruption.
Yes.
Yeah, I just would like to make an announcement because we have problems with the Q&A section. So if someone has any questions, please place them in the chat box. Oh, that's my only announcement. I'm sorry about that. Please proceed.
Okay, let me step back for a little bit. In the multi-target therapy study, the primary outcome was complete remission. The primary outcome, the response to the multi-target therapy was significantly higher compared to the control group of intravenous cyclophosphamide induction. Now, what you see here in this graph and figure is the cumulative probability of overall response that include complete and partial response together. Partial response defined as at least a 50% reduction in the proteinuria compared to baseline, and a urine protein of less than 3.5 grams per deciliter, with serum albumin of no lower than 3 grams per deciliter, and a serum creatinine no lower than 25% of baseline. Now, a much higher percentage of patients in the multi-target therapy group achieved overall response, 85%, compared to 68.6% in the control group of intravenous cyclophosphamide pulses every month, with an absolute difference between the two groups of 16.4% and a number needed to treat of 6. What you see here in this bar graph is the percentage of patients with adverse events according to the treatment groups. Total adverse events, serious adverse events, pneumonias, upper respiratory infections, soft tissue infection, sepsis, zoster infection, leukopenia were very similar in both groups. There was no signal that indicated that the multi-target therapy group had a higher incidence of adverse event compared to the control group of intravenous cyclophosphamide therapy. This slide illustrates a sub-study, a renal biopsy study. 14 patients in the multi-target therapy group had a kidney biopsy at the end of the induction of 6 months. 9 patients in the control group of intravenous cyclophosphamide had a kidney biopsy at the end of the induction of 6 months. When we look at activity, in both groups, the activity index declined significantly from about 11 points out of 24 to 2 points out of 24 in both groups. The chronicity index increased slightly in both groups, but there was no significantly difference in between the two groups. What you see here is an extended follow-up of the study, published subsequently in 2017. What you see here in this Kaplan-Meier plot in the y-axis is the probability of remaining free of relapse. Now, over 18 months of follow-up, 6 relapses occur in the multi-target therapy group. Another 6 relapses occur in the control group that initially received intravenous cyclophosphamide for 6 months and then subsequently azathioprine maintenance orally. There was no significant difference in the risk of relapse between the two groups. What you see here is also the extended follow-up of the study to 18 months of follow-up. This is what you see here in this y-axis is the probability of complete remission. Over an extended follow-up, that initial difference at 6 months of the induction phase was not any longer significant. Both groups over time by 18 months of follow-up achieve a higher percentage of complete remission. Now, what you see here in this slide in the upper panel is the changes in serum creatinine over time in the multi-target therapy group and the group that received initially cyclophosphamide and then maintenance azathioprine. In the lower panel, you see the eGFR changes. What you see here is that the renal function remained pretty stable in both groups. In the multi-target therapy group, the tacrolimus target level was between 5 and 10 nanograms per milliliters. There was no signal of nephrotoxicity with the use of tacrolimus up to 18 months using aiming for levels no higher than 10. Now, let me move now to the study published in Lancet last month, the AURORA trial, the efficacy and safety of voclosporin compared to placebo, an induction study. Voclosporin is another calcineurin inhibitor. All the patients in the study in both groups received initially intravenous pulses of methylprednisolone, 250 milligrams to 500 milligrams per day for 2 days, followed by oral prednisone, initially doses at 20 or 25 milligrams a day, with the goal that by 12 weeks, the patient remains on no higher dose of prednisone than more than 10 milligrams a day. In both groups, all the patients received a standard of care therapy with mycophenolic mofetil, target doses between 1,000 to 2,000 milligrams a day in split doses. 357 patients with biopsy-proven active lupus nephritis and a urine protein to creatinine ratio of 1.5 grams or higher if they have class 3 and class 4, or 2 grams or higher if they have class 4, and doubling of urine protein to creatinine ratio in the last 6 months for those that had a biopsy for more than 6 months, and eGFR no lower than 45 when enrolled into the study. 179 participants received voclosporin with a target dose of 23.7 milligrams twice a day, plus mycophenolic mofetil, 1,000 to 2,000 milligrams a day. 178 patients received placebo with mycophenolic mofetil, target dose between 1,000 milligrams to 2,000 milligrams a day. 357 participants with a median age of 32 years old were enrolled in the AURORA trial. As expected, 88% were females, 36% were of Caucasian ancestry, 31% of Asian ancestry, 13% of Black ancestry, and 21% of other ancestry. 33% were of Hispanic ethnicity, 67% of other ethnicity. Most of the patients in the study had class 4, 47%, 14% had class 3 lupus nephritis, 14% had class 5 lupus nephritis, 12% had the combination of class 5 and class 3, and 13% had the combination class 5 and class 4. The mean urine proteinuria at baseline ranged from 3.87 grams to 4.14 grams a day. The mean eGFR was 91 ml per minute per 1.73 meter square body surface area. What you see here in this bar graph is the primary efficacy outcome, complete response at 52 weeks, defined as a urine protein to creatinine ratio of 0.5 grams or less, accompanied by eGFR of no lower than 60 or eGFR between 20% from baseline without the need for rescue medication and without the need of using prednisone more than 10 milligrams per day for more than 3 consecutive days or 7 days between week 44 and 52. Complete response rate was significantly higher in the voclosporin group. 41% of the patients achieved complete response compared to 23% in the control group, with an absolute difference of 18% and number needed to treat of 5.6. A secondary outcome of complete response at 24 weeks was also significantly higher in the voclosporin group, with 32% of the patients achieving complete response compared to 20% in the control group, with an absolute difference of 12% and a calculated number needed to treat of 8.3%. What you see here in this graph is the probability of achieving a urine protein creatinine ratio of 0.5 grams per gram or less in both groups. 65% of the patients in the voclosporin group achieve a very low level of proteinuria, or no more than 0.5 grams per gram of creatinine excretion, compared to 44% of the patients allocated to the control group. This bar graph illustrates the percent of patients with adverse event by treatment group. Adverse events, overall infections, serious adverse events, pneumonias, confirmed decline in eGFR of more than 30%, events of acute kidney injury, mortality, or discontinuation of the therapy due to decline in GFR were very similar in both groups. There was no signal of safety difference between the two groups. What you see here in this graph is the changes in eGFR during follow-up. eGFR was measured initially every 2 weeks for the first month, and then every month thereafter until week 52, the end of the study. What you can see here is that the voclosporin group had no significant changes in the GFR compared to the placebo group. In the voclosporin group, there was a very strict follow-up of eGFR and changes of voclosporin dose according to the following changes. If the GFR during follow-up, if the GFR declined at 30% or more, accompanied by eGFR less than 60, the voclosporin was stopped temporarily, and the GFR was repeated, and voclosporin was restarted. When the GFR recovered to at least 20% of baseline, voclosporin was restarted at a lower dose compared to what was used when the GFR declined of 30% or more. If the eGFR declined between 20% and 30%, and the absolute GFR was less than 60, the voclosporin dose was reduced by 1 capsule or was reduced by 7.9 milligrams, or by 2 capsules, 15.8 milligrams twice a day, and the GFR was repeated in 2 weeks. If the eGFR declined, but the decline was no more than 20%, the voclosporin dose was maintained the same. Now, in the last study that I'm going to review in the next 5 minutes is the BLISS Lupus Nephritis trial, published in 2020. It's an induction study that includes 400, is the largest study so far completed, that included 446 participants with biopsy proving active lupus. A biopsy was required to be done within 6 months of enrollment, and patients had class 3, class 4, class 5, class 3 in combination with 5, or class 4 in combination with 5. The baseline urine protein to creatinine ratio to be included has to be at least of 1 gram a day or more, and the baseline eGFR cannot be lower than 30 mLs per minute per 1.73 meters square body surface area. All participants initially received intravenous methylprednisolone doses between 500 milligrams and 1,000 milligrams a day for 1 to 3 days, followed by prednisone 1 milligram per kilo per day in a tapered dose, with the goal to achieve no higher dose of prednisone of more than 10 milligrams by week 24. The patients in the study were allowed to receive one of the 2 standard of care induction regimens, either mycophenolic mofetil with a target dose of 2,000 to 300 milligrams a day in split doses, or induction with intravenous cyclophosphamide mini pulses of 0.5 grams every 2 weeks for 6 doses, followed by azathioprine with a target dose of 2 milligrams per kilo per day. The patients were randomized to receive intravenous Belimumab, target doses of 10 milligrams per kilo per dose, initially every 2 weeks for the first month, then every month thereafter until week 104. The placebo group received an infusion during the same scheduled times. 446 patients enrolled into the study with a mean age of 33 years old. As expected, 88% were women, 33% were of Caucasian ancestry, 50% of Asian ancestry, 14% of African ancestry, 2% were of American Indian or Alaskan Native ancestry, and 1% of others. 58% of the patients, and most of the patients had class 3 or 4, 16% had class 5, and 26% had the combination of class 5 with class 3 or class 4. The mean urine proteinuria or urine protein creatinine ratio was 3.5 grams per gram, and the mean baseline eGFR was 100 ml per minute per 1.73 meters square body surface area. What you see here in these 2 graph is the primary efficacy outcome, defined as a urine protein to creatinine ratio of 0.7 grams per grams or less, accompanied by eGFR no worse than 20% from baseline, or if the baseline was not available, a GFR no lower than 60, and no need for treatment failure, defined as the use of rescue therapy for lupus nephritis, or as the use of prednisone of more than 10 milligrams per day between week 76 and 104. By the end of the study of 104 weeks, more patients achieved the primary efficacy outcome. 43% of the patients in the Belimumab achieved the primary efficacy outcome, significantly higher response rate compared to 32.3% of the patients that were randomized to placebo, with an absolute difference of 10.7% and a number needed to treat of 9. By week 24, you can see that there is already a separation between the Belimumab group and placebo group in terms of the primary efficacy renal response outcome. What you see here in this other slide is the primary outcome analyzed in the time to event analysis, or survival using survival statistics. The cumulative probability of the primary efficacy outcome by 104 weeks was significantly higher in the group that received Belimumab compared to placebo. This set of figures illustrate the primary secondary outcome, complete renal response, defined as a urine protein to creatinine ratio of less than 0.5 grams per gram, accompanied by eGFR no more than 10% from baseline, or when not available, a GFR of no lower than 90 ml per minute per 1.73 meters squared by surface area, and no need for treatment failure. The response rate was significantly better when we look at the complete response efficacy outcome. 38% of the patients in the Belimumab group achieved a significantly higher response rate compared to 19.7% in the placebo group, with an absolute difference of 10.3% and the calculated number needed to treat of 10 patients. What you can see again here in this primary secondary outcome, a complete renal response, by week 24, there was in separation between the Belimumab group compared to the placebo group that was sustained up to week 104. This graph on the right side of the panel illustrates also the complete renal response outcome using survival statistic of type 2 event analysis. By 104 weeks, close to 50% of the patients in the Belimumab group had achieved complete response compared to about 30% of the patients in the placebo group, a significant difference. This figure illustrates the proportion of patients that achieve a urine protein to creatinine ratio of less than 0.5 grams per gram over time. In the Belimumab group, by week 104, 67% of the patients achieve a level of proteinuria of less than 0.5 grams compared to 56% of the patients assigned to the placebo group. This slide illustrates another important secondary outcome, time to renal related event that include the composite of renal worsening, treatment failure related to renal event, doubling of serum creatinine from baseline, progression to end-stage kidney disease, death from any reason. More patients in the placebo group achieve or develop an important renal event, 28.3% compared to only 15.7% in the Belimumab group. The use of Belimumab favored the reduction in the incidence of renal event with an absolute difference of 12.6% and number needed to treat of 8. What you see here in this graph is the cumulative incidence of renal event was significantly lower in the Belimumab group compared to the placebo group. This slide illustrates an outcome of renal flare after week 24. Renal flare definitions was as follows. At week 24, used as a baseline. The urine protein creatinine ratio values were used as baseline. Renal flare was defined as a reproducible increase in the UPCR of more than 1 gram if the baseline value was less than 0.2, or to more than 2 grams if the baseline value was between 0.2 to 1 gram, or more than twice the value at baseline if the baseline value was more than 1 gram, or a reproducible decline in eGFR of more than 20%, accompanied by proteinuria more than 1 gram per gram of creatinine excretion, and red blood cells or white blood cell CAS, or the need for renal-related additional treatment. More patients in the placebo group had a flare, 26%, compared to the Belimumab group of 14.4%. A significant benefit using Belimumab, reducing the risk of flare with an absolute difference of 11.6% and number needed to treat of 8.6. Now, what you see here in this bar graph is the percentage of patients with adverse events by treatment group. All adverse events, all infections, serious adverse events, pneumonias, infusion reactions, zoster, and mortality were very similar between the placebo group and the Belimumab group. In conclusions, where do we stand? In terms of induction, are multi-target therapies the new standards? Well, as you can see in the last 3 studies, multi-target therapies achieve higher rate of complete remission, which is a very good surrogate of long-term outcome without higher risk of adverse events. The efficacy of safety, however, of prolonged use of calcineurin inhibitors, in my opinion, needs more studies, particularly assessing the risk of relapse and nephrotoxicity over time. For maintenance, mycophenolate mofetil seems more effective reducing the risk of relapse compared to azathioprine group. Thank you very much for your attention, and I'm opening for questions.
Okay, thank you so much, Professor Contreras, for this informative presentation about the update and management of lupus nephritis. I just would like to remind everybody again that if you have a question, please place them into the chat sections. I received a couple of questions, which will start with the rule of repeating kidney biopsy. So the question says, we know that the consensus adopted it's to wait for about 3 years and then to perform either biopsy or withdraw treatment in patient with complete remission. So the question is, what do you think about following the same approach, but doing it earlier? We talk about 1 to 2 years without waiting that much and exposing the patients to a lot of immunosuppression.
I think that that's a very important recommendation for repeating biopsy, and a very important reason. You know, prolonged immunosuppression increases the risk of infections and increase the risk of cancers over time. So it is a very important recommendation for kidney biopsy. If you're planning to withdraw the therapy in somebody who's been for a long time on immunosuppression, one good way and safe way to know if the patient has high risk of relapse would be to do a kidney biopsy and look for activity.
Okay, so is there like any specific recommendation regarding when to do them? Surveillance biopsy, like we do them maybe after induction therapy, or wait for 1 year or 2 years?
Well, right now the recommendation is to do it at about year 3, right? Or whenever you are planning to withdraw the therapy. In my opinion, if you're going to use a regimen that includes a calcineurin inhibitor, it's a good idea to repeat the kidney biopsy by 1 year of therapy, and then every year thereafter. Now, we know from the experience in kidney transplantation that prolonged use of calcineurin inhibitors can give you nephrotoxicity. And we know from also studies in kidney transplant that the accrual of chronic changes increase over time with the use of calcineurin inhibitor, which is something that we don't know yet in lupus nephritis.
Okay, great. So how about the optimal duration of subsequent therapy, which basically is unknown? Most of the time we continue immunosuppression for 3 years and then we do a biopsy. What's your opinion about the optimal duration?
It's something that it hasn't been studied well. You know, many of the guidelines indicate that 3 years is probably more than enough, but we still don't know. What I can tell you is that we concluded a recent study. We call it the mycophenolate mofetil withdrawal study, in which we enroll a little bit over 100 patients in a multi-center study in the United States. And we enroll patients with lupus nephritis. Those that had remained with proteinuria less than a gram a day for at least 2 years on low dose prednisone and a stable dose of mycophenolate mofetil. And we also exclude patients without lupus nephritis. The results were released in the American College of Rheumatology meeting last year, and the results showed that a withdrawal plan over a year did not increase the risk of relapses. Now, the paper is being written. Soon we're going to have more details about the result of that study.
Okay. Also, I have another question similar to the previous one, but talks about patient with lupus and very mild proteinuria. Let's say less than 500 and normal kidney function with no active sediment. You know, the guidelines does not recommend biopsying those patients. Do you have any opinion about that?
I concur with the guidelines. I don't think that there should be and the biopsy is indicated if the proteinuria is minimal, if the patient eGFR remains normal, right? Now, so I really fully concur with the guidelines. However, I do think that a biopsy, you can make a case for a patient with minimal proteinuria if the biopsy is going to help to determine what would be the best option for example, withdrawing therapy that has been used for prolonged time, immunosuppression that has been used for prolonged time.
Okay. Okay, we cannot finish a talk about lupus nephritis without talking about rituximab. And my question is there any role of rituximab in lupus nephritis management? Because we talked about this in the past, especially after having too many negative studies, but we still see rituximab being widely used.
Well, rituximab is the first generation of anti-CD20 blockers. Now, the studies done in lupus, none of them really show a significant benefit. But recent studies using new generation of anti-CD20 blockers has shown efficacy benefit and safety benefit as well. So what I would recommend in terms of anti-CD20 therapy is that we wait for the Regency study. That's a phase 3 study that is now comparing obinutuzumab, which is a new generation of blockers against the CD20. The study is well ahead of enrollment, and my hope is that that study result will be released in the next couple of years. As part of my practice, I don't use rituximab frequently in my practice. I have used it before, but it's not really one of my first choice of therapies in the treatment for lupus nephritis.
Okay, the next question talk about, we're currently in the COVID era. So do you usually recommend vaccinating patients with active lupus nephritis before starting induction therapy? So you wait till they get vaccinated?
If you can wait and the patient renal function is not rapidly changing, or the disease is, lupus in general is not very active and life-threatening, my recommendation is that you complete the vaccination for COVID. Now, if the patient has rapid changes and deterioration in the kidney function or has life-threatening activity from lupus, you can still would recommend COVID-19 infection during the therapy.
Okay, so I have a question here from Professor Mutwalli regarding the earlier question that we talked about minimal proteinuria, and he mentioned here, did you notice the fact that there is no good correlation between the urine findings and the finding on renal biopsy? Therefore, maybe biopsy sometimes could be indicated in those patients?
Yes, that's very true. You know, studies in terms of correlating clinical parameters that we use to follow renal patients and biopsy findings are not very good. They're not correlating very well. And one of the reasons, in my opinion, is that the kidney biopsy is like a cross-sectional view of the patient, as opposed to, you know, following the patient's proteinuria. So that's the reason I think that the correlation is poor in many studies. Now, if you have a high suspicion of severe lupus nephritis, a class 4, and the patient has minimal proteinuria, and you feel that the biopsy is going to help you to make that final decision of using, for example, multi-target therapy, I would say do it, because that would be the best way that you can discuss better with the patient the benefit of using multi-target therapies.
Okay, excellent. That will take us to the next question. You just talked about the multi-target therapy, which is associated with higher risk of infection. So when do you really consider using multi-target therapy in patients? Do you have specific target of patients that we probably advise using multi-target therapy?
Well, in terms of increased risk of infection, these last 3 published studies did not really show that multi-target therapy approach increased the risk of infections when you compare to standard of care. If you remember those bar graphs that I showed you for the AURORA and the BLISS-LN and the multi-target therapy study in China, the adverse events were very similar between the two groups. So nowadays, with these 3 landmark studies, I'm initiating patients very quick, within 45 days, 60 days on multi-target therapy approach, with the goal to achieve a much higher complete response rate, which is a good surrogate what's going to happen in the next 5-10 years. I'm not really more conservative anymore after these studies were published in terms of multi-target therapy approach from the beginning.
So the common scenario that we usually face, like using an induction therapy such as cyclophosphamide, followed by a big MMF and prednisone, and the patient still in partial remission. Do you recommend starting multi-target or initiating calcineurin inhibitors in those patients, or giving them more time?
If the patient fulfills criteria used in the study, in the BLISS-LN, persistent proteinuria of 1 gram or more in patients like that, or in the AURORA study, persistent proteinuria 1.5 grams or more, or 2 grams or more with class 5, I would use multi-target therapy. I will add another regimen if I don't see a good response. Why I do that? Because those are what we call partial responders. Partial responded, if you remember in one of the first slide that I presented, partial responded, they do better than no respond, but they don't do as well when you follow them for 10 years because they have a higher risk of relapse or worsening kidney function.
Okay, regarding your last study that you presented with the Belimumab, with your experience, you showed us the side effect in both groups, and it was similar. But in your experience, is Belimumab associated with more long-term complication? And have you noticed increased risk of infection or ICU admissions in patients who receive Belimumab?
In the study, there was no increased risk of infection compared to the placebo group. So yes, you see infections, but not at an increased rate compared to placebo. Now, the study lasted only 2 years, and it went into the extended phase of an additional 6 months. And I reviewed already the data for the entire 2.5 years, and there's no increased risk of infection either up to that time. So I don't think that using Belimumab for longer than 2 years is unsafe, and I'm using that. However, I'm using more the subcutaneous form of Belimumab that is also approved in the USA by the FDA, which is much easier to administer to patients who require therapy, and including Belimumab.
Okay, the last question is, do you recommend using antibiotics prophylaxis in patients receiving Belimumab?
Only if the lymphocyte count is too low. And what I mean lymphocyte count too low is if I find that the lymphocytic count is running less than 1,500, what I do with them is I do what we call a lymphocyte subset. And if I see that the CD4 count is less than 400, I put them on Bactrim or another therapy to prevent pneumocystic carinic infection. But other than that, I don't use prophylactic antibiotics when I use immunosuppression in lupus patients. So
you continue that till the CD4 count goes up?
Yes, I follow the lymphocytic count and CD4 count.
Okay, I think we covered most of the questions. Again, on behalf of all participants and the Society of Nephrology, I would like to thank you, Professor Contreras. It's a pleasure to have you with us. I will turn the mic to Professor Mutwalli for final comments and closure of the session. Professor.
Thank you, Professor Contreras. Really, it was very educative lectures. I really enjoyed it. And I have to admit that I biopsy all my patients. So maybe I'm so aggressive. I thank you very much indeed for your sharing this lectures, this tutorial, Dr. Sami. It was really a good moderating, and really very happy to have both of you with us. I have to thank GSK for the contribution and the support for this webinar. And if it wasn't for them, we couldn't proceed with this webinar. Thank you very much, everybody. And I have to apologize to our participant who could not attend. We reached maximum 3,000, and there are still people wanted to enter the webinars. We couldn't, so we channeled them to, detoured them to YouTube. And I thank everybody. I thank the participant. I have to thank also the society for the, continuous educative support. Thank you, everybody, and good night.
Good night, everybody.